Once again, welcome to Virtual Wound Rounds. My name is Frank Aviles. Today's topic is wound technology. How are we going to use technology to enhance patient care? I am the clinical coordinator at Natchitoches Regional Medical Center, and I've been able to use some of this technology, and I get excited when we talk about this. So tonight, our panel will discuss the utilization of technology to enhance patient care. Now, we made advances with dressings and also advanced modalities, but that's to intervene on wounds. But we're coming to a new era where we have this technology that can help us predict, recognize, validate, and impact the care that we provide to our patients. Tonight, you're going to hear our expert panel talk especially about a point of care fluorescent imaging device and how it's helping us. Next. So I do want to thank, this will not be possible if it wasn't for today's sponsor. MolecuLight is our sponsor, and we appreciate of what they're doing. We're going to hear more about this fluorescent imaging device. So let's go ahead and go to the next slide. It is an honor for me to say that all these great clinicians have been part of the virtual wound rounds. We started this in an effort to educate not just students, but also clinicians during COVID. And we are continuing to affect people, not just in the US, but globally. So these are all the clinicians that have been part of the wound care rounds. So thank you. Next. Housekeeping rules. What we're going to be talking tonight is educational purposes only. This does not constitute replacing medical care. Now, HMP, nor the moderator, will be endorsing any products, but we're going to talk about the science behind the product so we can use it properly. We're not providing CEUs, but if you require a certificate of attendance, email us and we'll be happy to provide you with one. Also, please, we have an expert panel with a lot of knowledge. If you look at the bottom of your screen, make sure you use the Q&A section with any questions you have for these professionals. Throughout the presentation, we'll take time to answer your questions. Next. So as far as an agenda today, we're going to talk about the technology in wound care overall in general. As we're seeing, there's a lot of changes and we're getting patients that are more in the chronic state. We're going to talk about the science behind the product, and we will do more. We're going to learn about some of the research being done on this device, the fluorescent imaging device. Next. So when we look at wounds, you're going to see a standard image on the left. And then on the right, this technology is showing us something. So we're going to learn about what it's showing us and how it can change your practice. Next slide. And now, let me introduce the panel for tonight. I'm very excited to have these four professionals. We have Dr. Charles Andersen. He is the Director of Wound Care at Madigan Army Medical Center. We have Dr. Alton Johnson, a podiatrist and a clinical assistant professor and attending physician at the University of Michigan School of Medicine. We have Dot Weir from Saratoga Hospital Center for Wound Healing and Hyperbaric Medicine. And also Martha Kelso, CEO, Wound Care Plus. I want to welcome all four of you and thank you for your time on this terrific topic. Is there something that each of you want to say before we start? We'll start with Dr. Andersen.
Oh, just a little bit of a bias so people know my background. So I'm a vascular surgeon by trade. I've been involved in a limb preservation initiative for the past 25 plus years. My bias is that practicing limb preservation and practicing wound care is a team sport. And I'm committed to education and I'm very proud to be part of this. Thank you, Frank.
Well, thank you. Dr. Johnson?
Not too much to add, just happy to be here and excited for today's panel discussion. And I love wounds, love challenging wounds, so be great to talk about technology and wound care.
Well, good, thank you. Dot?
I echo that. I'm very happy to have been invited to participate tonight. My bias is that I'm a nurse, and actually I've been a nurse for a long time, but I've been in wound care for 41 years. And where we are today with technology is pretty darn exciting. And I've been an outpatient since 2001, so I'm in my 20th year as outpatient. And my current soapbox is all around wound cleansing, and I think that will probably come out tonight.
Well, thank you, Dot. And Martha.
Thank you so much. I'm excited to be here, joining my friends and colleagues on the panel list. I always appreciate working with them on multiple levels. One of my biases is this is a diagnostic study that I find so exciting. And our company was one of the early adopters in the post-acute care setting. We're one of the first groups that actually used this in long-term care. And we're going to talk more tonight about how it's impacted the level of care that we provide. So thanks for having me.
Well, thank you. And thank all of you for being here, and thank HMP for allowing this to happen. So let's start with Dr. Andersen. Dr. Andersen, you've been around in the field and talking about limb salvage. What has been the biggest challenge throughout your career when it comes to helping wounds or healing wounds?
I think the big challenge has been to put together a team that has a passion for a goal, and our goal is to prevent amputations. Now, that being said, wound care is a significant part of that. So we have vascular surgery, podiatric surgery, and wound care. And being able to evaluate wounds and treat proactively and get those wounds healed rapidly is the goal. So especially in the diabetic foot wounds, which we take care of a lot of diabetic foot wounds, the longer a diabetic foot wound is open, the more likely it is to become infected and to get osteomyelitis and ultimately end up with an infection. So if we have a tool, as we do now, that can rapidly assess the presence of bacteria and then react to that appropriately, very proactively at point of care, then that's a big change and a big improvement for wound care when it comes to wound care and limb preservation.
Yes, and I agree with that. Having these tools are definitely making an impact. So let's talk about the benefits in general of technology. So Dr. Johnson, now when I met you, you were using a lot of different devices, but in general, how is technology changing your practice?
I would say definitely. I mean, when it comes from a documentation standpoint and clinical imaging capture, I mean, sometimes just the fact that you have a better picture and more accurate measurements using the technology devices that's out there, it makes your life easier. And then it also helps with patient education. So that's another aspect too. So if you're able to actually pull up, graphs and charts that these softwares and hardwares capture for these wounds, it kind of helps put it in perspective for a patient, because they're seeing the wound every day or every other day when they're changing it, and they don't, they're kind of getting exhausted. But if you can pull up a graph it's automatically populated, which majority of the software is out there that do it for the wounds, it kind of helps them to kind of stay motivated to kind of get this wound healed. And it also shows you as a clinician or a provider how you're treating, how good you are at treating this particular wound, and kind of helps you reflect and almost like playing football or something, get the retro replay of it. So it's great.
Yeah, and you bring up a point, and Dr. Andersen also, I'm a physical therapist. So when I have 10 doctors in the wound care clinic that I work with, and when I can show an image of something, it kind of gets a faster attention. So I definitely see that as a benefit from my standpoint of view. Let's go back a couple slides and let's talk about this technology, the fluorescent imaging that we're talking about. So Martha, I know you've had a lot of experience with this. Tell us what we're looking at.
Yeah, so the photo on the top left is normal photography. Sometimes great light, sometimes not so great light. Obviously, we have a callus formation. We have erythema around the wound bed. But when you use MolecuLight or the bacterial fluorescence, you're actually seeing a porphyrin-producing bacteria. So the red imaging and even the pink imaging in the top right photo is a positive indicator for 10 to the 4th power of porphyrin-producing bacteria. In the bottom left-hand side, we have a wound. It doesn't look great. It appears possibly clinically infected. We put it under bacterial fluorescence, and we have a positive indicator, that bright green glow, which we know is for Pseudomonas. The FDA has now approved this device that when it fluoresces green, we know that's a positive indicator, hands down, for Pseudomonas. I like to call it guesswork gone. When I'm stuck relying on clinical signs and symptoms of infection, we know, particularly in the elderly, it's not accurate. And so bacteria and infection goes misdiagnosed or underdiagnosed, which can be dangerous.
Yes. And for those of you that are joining us for the first time, I do want to tell you that the panel has not seen this presentation. So it's kind of unscripted a little bit. So, but let's go ahead and move forward with the slides. One more. Okay, Dot, I heard you say you've been doing this for over 40 years. Both you and I have seen how technology has changed from the brick phones. I used to have one, and now we have smartphones. So let's go to the next slide. And there's so much technology out there. Okay, this is some of the other ones that are out there, from measuring devices to even having these goggle lenses you can put on. So let's go to the next slide. Okay. And when you're looking at these kind of wounds in your clinic and your practice overall, what comes to mind?
I think anyone would look at these wounds and know that they need attention. And one of the first things that they need is debridement. I mean, you always look at something from the context of, do I think this is clinically infected? But from a day-to-day care, we're going to go after those edges. And I think, as the images showed from the fluorescent imaging, the bacteria that is harbored in these edges of wounds underneath scales. Are the other two going to pop up here? Or is it just these?
No, just these two.
Okay. As Martha pointed out, you know, oh, there you go. So the green you see with a lot of scales and things, but the hot white is the indicator that is right there that they're pointing to is where the Pseudomonas is. And this doesn't say that this wound is infected, but it does say that there's bacteria there. And so when we look at wounds like this, we say, oh, well, these are chronic wounds. And I think we need to differentiate chronic from hard to heal. And hard to heal wounds are really more those that have some barrier there that's keeping them from closing or keeping them from moving on. And this imaging has given us the opportunity to, in real time, as Martha pointed out, see what's there and help us to even guide us in our cleaning and our debridement. So, you know, this has taken us to a whole new level on one of my pet peeves, and that's improper cleaning. Sorry, I do have a dog here, but I'll keep muting her.
It's all right.
Frank, I'd like to also point out that halo effect in the top right photo. And the reason why that's clinically important is that's hidden under that area of eschar or callus formation buildup. And sometimes our patients get sick of us debriding and taking a sharp instrument to them. But when you use bacterial fluorescence, the patient can see with their own eyes that there's hidden bacteria at 10 to the 4th power under that non-viable or even senescent tissue. And sometimes that's the push your patient needs to go ahead and allow you to debride and get rid of that unhealthy tissue so we can get rid of that bacteria. So I just wanted to point that out. Thank you.
I do have several questions from the audience too in regards to this slide.
All right, go ahead.
Yeah, so the first question is, so when you see fluorescence, would you add antibiotic? I think that was towards Dot. Then there's a second question I'll ask after she addresses that. Yeah, unmute yourself.
I want to mute the dog at the front of me. No, not necessarily. I mean, that, you know, infection's a clinical diagnosis. So we'd have to see the bigger picture, but what this imaging shows us is where there is bacteria. It doesn't necessarily show greater than 10 to the 4th, as Martha has pointed out, but it doesn't show that the wound is infected. So we know it's there, and we know the next thing is that these can replicate, form biofilm, and invade into deeper spaces and ultimately cause an infection. So you don't add an antibiotic just based on the imaging.
Understood. Okay.
Dr. Andersen, you've had success with targeting the area of debridement to remove bacteria from the wound bed, correct? And then fluoresce after the fact, and bacteria is gone after your sharp debridement?
Yeah, let me back up just a little bit, because the last word that Dot used, I think, is exceedingly important. So when you look at that upper picture, that's a diabetic foot ulcer on a plantar aspect of a foot. Now, I spend every day teaching residents, and the residents love to go from patient to advanced technology, and they miss all the in between. And that's a big mistake, that you can react to this image and you can say, gee, there's callus there, there's bacteria in that wound, you can do an appropriate debridement. But if you don't offload this patient and treat the disease, you've not done appropriate wound care. So be careful treating technology. These are patients that have disease that needs to be treated. Back to your point, we do a lot of what we call MolecuLight assisted debridement. So when we would see a wound like this, we would not only debride that callus, but we would debride that wound and then rescan to make sure that we've removed the fluorescence, which indeed, most of the time with appropriate wound cleansing and appropriate debridement, you can remove all of that fluorescence.
Good point. Let's go to the next slide. Actually, I'm sorry, Dr. Johnson, you said there was a second question?
Yeah, I think Dr. Andersen kind of hit on the second question. Essentially, they just wanted to know if you had any negative imaging of fluorescence. So basically the question is saying that, every wound is going to light up. But Dr. Andersen basically said, yeah, that's possible. So then essentially they just want to know if you had any imaging where it shows the wound doesn't light up. But that's probably something you would have to, send after, because I don't know if that's in your presentation.
Towards the end, I'm going to try to shoot a video, and I have a folder with a lot of images I could find.
Perfect.
Well, great. So let's go to the next slide. And so Martha, when I saw this, I saw that the device actually does documentation too. How do you use it in your clinic, and what's the workflow like?
So generally speaking, we have medical decision-making built into our database that helps meet medical necessity for this device. And there was actually a study done that allows decision-making or that decision tree. And so I would say that every practice is probably a little bit different, but our practice, if we have a wound that's stalled out, it's not behaving like we think it should or like we anticipate based on current treatment plan, foul drainage. Obviously, we can't smell anymore with our N95 masks on, but any of those symptoms. And then we also do it before we reach for advanced modalities like CTPs, because we don't want to put expensive CTPs on a wound that's clinically infected. In our setting, we cannot get perfectly dark. So we actually have to put a dark drape on and put the device under the dark drape. So it's a nice dark environment where we can clearly see the fluorescent image. Now in the image you have, Frank, they've done a great job at darkening the room and the image is nice and clear. But the device can help measure or even do digital wound area measurements and help that clinician determine real-time wound assessment, just like the slide says, treatment planning and documentation. I love this diagnostic study because it's non-invasive. So it doesn't touch the patient. They're not afraid of pain. And then again, it helps with proactive wound care and patient engagement. They really like seeing those photos week to week. And I will say that there are times we absolutely thought the wound was clinically infected. We were able to perform MolecuLight and it did not fluoresce. And so it changed our treatment plan away from culturing, away from potential antibiotic usage, so on and so forth. I'll bet Dr. Johnson's had same or similar cases in his practice.
Definitely.
So Martha, you mentioned, decreased use of antibiotics, but have there been any studies on comparing how they decreasing using any antimicrobial dressings based on the readings from MolecuLight?
I don't have all their studies memorized. Dr. Rennie might be able to answer that question better for us. I can tell you in our clinic, we have significantly reduced antibiotic usage, culture usage, and antimicrobial usage. Upwards of 80 to 85% of the time, it changes our treatment course. What we thought we were going to do when we walked in that room to what we actually did when we were walking out of the room. Dr. Rennie stated that there is a study from NHS that reduced antibiotic usage by 33%, and then antimicrobial dressings by 47%. And that's game changing. It's game changing for our chronic wound care patients.
Yes, yes, you're right. Let's go to the next slide. So, Dr. Johnson, I'm going to put you on the stand, but if you look at this, does this one look like has elevated bacterial burden?
Most likely it does, due to the, it's like a crevice. So it's just harboring in there, and not, with good temperature, and yeah, definitely can cultivate some bacteria. Burden, I don't know if about infection, but definitely colonization.
All right. So before we give you the answer to that, Dot, let's talk a little bit more about hygiene. Let's go to the next slide. Oh,
Up, take it away.
so it does. It does. So actually, hold on, Dot. Martha, can you tell me a little bit more about what we're seeing with this fluorescent image?
Well, there's definitely bacteria at 10 to the 4th power draining out of that wound, and it's also impacting the skin. So when we see that bright red glow, we are talking about porphyrin producing bacteria. And now, obviously, there's a lot of different porphyrin producing bacteria. So this is a wound that we would anticipate culturing. Our practice generally does PCR testing or tissue cultures. We do not do swab cultures. But it is something that you could use cleansing for versus maybe reaching for bacteria, things like hypochlorous acid or things that kill that topical bacterial load. However, if you reach for a tissue culture or PCR test and send it off, it would tell you which type of bacteria is producing that porphyrin, that bright red glow. I hope that helps answer the question.
Yes, yes, it does. Thank you very much. Let's go to the next slide and let's talk about wound hygiene. I did look around in the dictionary, and it defined it as a collection of practices to promote and preserve health or a condition involving the use of such practices. Let's go to the next slide, and Dot, go ahead and tell us what you have here.
Well, this was when we were first playing around with the camera, the imaging device. When you use this enough and you look at things, you start getting used to the green, because anytime you have scales and things, they tend to turn green. It's the hot white and the pink to red that we look for. I think this is a video just showing the cleansing. Is that the one that you have?
Yes.
Yeah. So as you start to clean, and this is something, Frank, this is what I wanted to point out. As you clean, you can see you're moving the bacteria around. Now look at the hot white on there. I'm cleaning in between the person's toes. And as you can see, that gauze is pretty laden with bacteria. And as I teach wound cleansing and wound hygiene, I encourage people, as they're cleaning, switch out your gauze. And that's a good reason why you should do that, because you can see how it's all just trapped onto the threads of the gauze. And so we need to put that gauze down and get another one. But basically, we use it. Yeah, and I took another video yesterday, but this will suffice, showing as we are able to clean it. And a lot of times it's sitting on the peri-wound skin. And so that's why with wound hygiene, we recommend 10 to 20 centimeters outside of the edge of the wound to clean the skin, because there is bacteria that's been sitting underneath that dressing. So at least wherever the last dressing was, if it's a multi-layer wrap, clean the whole leg or up to the next joint, so that you don't leave that sitting on the skin. It may not be on the wound. It may be just colonized on the skin, but that can then go over and contaminate the wound. So that's what you're looking at. But look at that gauze. It's just loaded with it.
What is that in the background, Dot?
What's that?
What is that in the background? Is that their original dressing?
I'd have to wait and see. Yeah, maybe. Oh, you know what? These are podiatry chairs. And so it's probably the tray underneath where we drop stuff down. Yeah, that's exactly.
Okay.
Yeah.
So
That's
Dot, something that we've started to do is almost a routine, is when we're seeing a patient and we take off the dressing, we scan the dressing.
Is that just not so telling? Yeah, we do too.
So not only the dressing, but also if we're doing negative pressure therapy, we scan the foam. And many times we'll see bacteria in either the dressing or the foam that we don't appreciate in the wound, but that tells us that that drainage does indeed have bacteria.
Well, what it would tell me is if I saw it in the dressing and not on the wound, that I have a pretty darn good dressing as far as how well it's absorbing and lifting debris off the surface.
It does, but it tells you that it's removing bacteria.
Yep, for sure.
Yeah. No, and Dot, let's go ahead and take the time. You mentioned the other video. Let's see if we can bring that in now.
It's really just the same thing. What I wanted to show was the gauze and how important. I mean, there are some nice devices for cleaning. We do a lot of times, so talk about, Martha was mentioning a dark room. Our clinic is in an old Sears building. And so we are totally inside. So we don't have to use the drape at all. We have no windows, which is not usually a good thing, but with this, it's a very good thing. So we have nice dark rooms, and we'll have the lights off and the imaging on, because it fluoresces. You can see exactly what you're doing to not only do cleansing, but when we're using our ultrasound device for debridement, then we will be using that too. And it helps us to target not just the wound, but also the peri-wound skin also.
Has anybody used this device on wounds that are coming grossly infected? And do they look any different from these pictures we're seeing, these images?
Well, I think it depends on the type of infection. One thing that Martha said that I'd like to comment on it is, certainly a positive scan is an important piece of information, but a negative scan doesn't necessarily mean that you don't have an infection. So, for example, strep does not show up with this device. So you can have a strep infection that you're not going to see. So it's a piece of information that we need to put together with all the other clinical assessment that we do on these wounds.
Very good point.
Yeah.
We haven't talked about it yet, Frank, but the device does take video. This is the right, Dot. This is your video from the device. Right?
Yeah, when we're doing the ultrasound, you can see it just streaming off with the water. Very cool.
Really? I wasn't aware of that. That's exciting. I can't wait to try it. So
the other thing that with the video that we've gotten used to do, so we will obviously scan the wound, assess the wound, but then we'll take the video and we'll go around the foot if we're examining the foot. And the interesting thing is, in our diabetic patients, we've found that many times we'll see colonization between the toes. Now, usually that can be removed just with good cleansing, but it tells you that that's an area that needs to be cleansed. And sometimes what you'll see in addition to that colonization is you'll see a little fissure that you miss it unless you scan. You see the bacteria, you spread the toe, and you see a fissure, and that fissure can be then the source of an infection in the foot. So we take advantage of that video, and we just scan the whole area.
all right. Let's go to go ahead.
We have found several hidden abscesses by using this device that would have gone unnoticed or undiagnosed. And again, we're dealing with people that have so many comorbidities, polypharmacy, oftentimes, financial distress, physical distress. And so missing an abscess, on your weekly visits, waiting another week when there's a hidden abscess sometimes is the difference between sepsis in the hospital or continuing to heal that wound. And those are the moments for me that, gosh, talk about limb salvage. When you find a hidden abscess that you could not detect with the naked eye through clinical signs and symptoms of infection, practically absent, and you have the opportunity to intervene, do your incision and drainage right there, it's again, game changing. It takes the guesswork out of the practice,
Yeah. And I'm curious now to see what the dressings are looking like, to scan the dressings afterwards. I think that's phenomenal. Like Dot said, now I'll be able to see which dressings work in our clinic. Let's go to the next slide. There you go, Dot.
Okay, so I use this every time I talk about wound hygiene, because if you look at the picture, then these are not mine. I subsequently have some. This was before we had our imaging device. But if you look at the picture on the left, I know my pointer won't show, but the bottom arrow is pointing to necrotic tissue. You expect to have bacteria there. And then up at the top, there's a little bit of what most people would call slough. And then down below, there's some like superficial skin loss and some old dressing. And there's another picture coming up after this. But if you look down, so you can see the red color, we knew there would be bacteria in that dead tissue. Another good reason why we need to get rid of it as quickly as we can, because it is holding on to bacteria. But look at that very superficial area down below. You know, that probably would close, but it's harboring Pseudomonas. And that's what they have recent clearance from the FDA to make a claim about this, that it does identify Pseudomonas. And so that's why wound hygiene is so important. Cleaning my friend Terry Swanson out of Australia was the first person I heard say this, we're squeezing saline with a little pink thing onto wounds and calling it a day. And as she says, that's anointing a wound. It's not cleaning a wound. We need to clean it like you mean it and really do a good job. We use hypochlorous acid on every single patient in our clinic. And that's the kind of thing that we need to be going after. Show the next one.
Hallelujah, Dot.
Okay, so look at this like fifth lateral med head here. That wound is about to close. I mean, this is not keeping it from closing, but look at the fluorescing where that macerated skin is. So doing a better job of absorbing exudate, protecting the peri-wound skin, because when you macerate, then you're going to have another place that these bacteria just love to sit. And then again, up at the top, it looks like old treatment residue. There's contamination there, and there's certainly Pseudomonas, as evidenced by the hot white color. So I think it just drives home our cleaning message that we need to do a better job of this.
Dot, can you go back to the first picture?
Sure. Well, I can't, but somebody can. There you go.
So in the upper image, you see a wound that has some slough, but there's fluorescence in that slough. Did you debride that and did it go away?
This is not my image. This is one that I got from the company way before we had our imaging device, because I didn't have my own. And so they gave me these. I don't know who to attribute these pictures to other than MolecuLight. Somebody from the company gave me those. So I don't have an answer on that.
So this is a real good example of when you see that necrotic tissue there, and now you have an image that indicates there's bacteria in that necrotic tissue, that when you debride that and rescan, most of the time you can get rid of that fluorescence. Now, I think that's very important, because if you leave that necrotic tissue there that's colonized, that just sets the stage for that infection to become more invasive, for the bacteria to cause a more invasive, or to actually cause an infection.
Conversely, we've had clinicians debride that necrotic tissue. The wound bed looks amazing. You fluoresce again, and it's still highlighting. Part of the wound is still highlighting. So you can try to debride again, but that basically means there's infection down in the tissue. And so we were able to do targeted tissue culture, where we now know what part of the wound we need to culture to determine what kind of infection. Where, previous to this device, we were just culturing whatever part of the wound looked the worst, whether there was bacteria in that part of the wound or not. You're just guessing.
Did that also, Martha, change what dressing you utilized?
Yeah, and so we would reach for antimicrobials or, hypochlorous acid or something to that effect, 100%. Where, if a wound bed's clean, you're thinking, maybe collagen or something like that, but you don't want to put collagen in a wound bed if it's infected, because the collagen can feed infection bacteria. Collagen's going to feed whatever's in the wound bed, unless if it's a collagen that has an antimicrobial built in. So yeah, it absolutely changes your treatment decisions.
Yeah, and Martha, you mentioned that you're using this before applying cellular tissue products. Are you noticing that you're having better outcomes now that you're targeting when to apply them?
We are. We actually had a gentleman that, and he's been in the news. So, but was a COVID patient. Thought he was. The doctors had pronounced him brain dead. They went to go pull the plug. He woke up while they were disconnecting the plug. and was in the hospital another 7 months, discharged with a wound down to bone. The wound had osteomyelitis. So we were able to do targeted debridement of that bone. The bone was obviously flaking off and soft. Once we got the wound bed cleaned up, we were able to start doing CTPs on that wound. Every time there was a fluorescence, we would remove the area that was fluorescing, apply the CTP. Keep in mind, we were told this will never heal. We healed him in under 8 applications.
Wow.
8, all the way down to bone, 8 applications of a CTP. Now we're not stuck with sepsis, recidivism, rehospitalization rates, all the ugly words that come with chronic wounds that don't heal. And so, we credit it to bacterial fluorescence and CTP usage, 100%.
I have a question. Back to what you guys were just saying, because it makes me think. So Chuck, you're saying you debride that. If you still see fluorescing, then, and Martha, you would then culture and treat. I assume you still take the area around the wound into consideration. So I don't know if you know who Thomas Barnsholt is. He's a biofilm researcher from Denmark, and he just published this great paper, and I can send it to anybody that wants it, on the mental model of biofilm, because we see all these cartoony pictures of biofilm. They look like mushrooms. And so I think we all have this idea that we can just scrape the top off and the biofilm's gone. I've seen so many speakers say, well, I cleaned off the biofilm, and we know it penetrates down into the tissue. Let me just pose this question, because I don't know the answer. I'm just curious. Could we be down into a biofilm where now we have exposed bacteria? And if we just used antimicrobial, a topical, it would take care of it? Or do you always feel like if you have debrided and you see what you think is healthy tissue, do you always go after that? That's not a challenge, it's really just a question.
We almost always do PCR testing, and PCR testing, as you know, will say, gosh, this bacteria is present in the wound, but it's not causing an issue. Or this bacteria is present, it's definitely causing an issue. And it's actually why we do PCR, so that we're not treating bacteria that doesn't need treated. We're not adding polypharmacy and giving people C. diff and all other kinds of fun secondary unintentional problems.
Does my question make sense? You see what I'm asking?
And I think you have a very good point, Dot, that you see some bacteria in that necrotic tissue, even though you remove the necrotic tissue and you have, quote, a negative scan, we would say we would not put the patient on antibiotics, but being there was bacteria in that wound, we would use an antibacterial type of a dressing.
Yeah, but I'm thinking even if you saw still a somewhat of a, maybe it's down to pink. I don't know if that makes a difference in the numbers or not. Yeah, it was just a curiosity if we maybe just unroofing or exposing bacteria that was trapped into a biofilm that we now have exposed, and something topical might go after it. Just
very good point.
Well, and if you're listening, please, it's time to see if there's any questions. Feel free to write it on your Q&A section at the bottom. And Dr. Johnson, do you have any questions?
Only thing I said is how do we get our fellow providers, to try this technology out? I mean, we can talk about it, but how do we get people to use it is one of my questions. I think Dr. Andersen kind of hit at it. More of so using it as a secondary modality, I think, is kind of the best way to go about it. But I think that's probably for Dot and Martha, since they use it pretty often too.
I tell you what really convinced us that we were familiar with Dr. Serena and his initial paper. So we brought a device into our clinic and basically did the same thing that he did on his original paper. We said, we're going to assess a wound. We're going to make a plan based on our clinical assessment. Then we're going to go ahead and scan that wound, and we're going to keep track for our own trial. Did that change what we're going to do? And what we found was it changed what we were going to do. Like our first time we did this was like 60%. That's hard to argue with in my mind, that using a point of care device, you can say you're going to change something 60% of the time. Now, the last paper that Serena just published, it's now 87% of the time. So you see what the eye can't see, and then you you change your clinical plan based on that.
I think that's a good way of viewing it.
And that's comparable to what we found in clinic. It was interesting because Dr. Andersen, when he first published his first paper, and the numbers came out that were what, 60 or 67%, I thought that's kind of low, because what we were seeing was 85 to 90% of the time. But I would say 95% of what we treat is aged or elderly population that don't have the inflammatory responses, the cascade effect like your 40 to 60-year-old population. And so oftentimes they don't have those clinical signs and symptoms that we are all trained on in nursing or medical school. They don't have it until they are sick. They don't run a fever until they are septic. And I'm just making global statements. I know some elderly may run a fever, but overall, and we were even showing up to clinical rounds saying, gosh, the wound looks great, keep doing what you're doing. And then we'd find out 2 or 3 days later, they were shipped to the ER and admitted for sepsis and sepsis protocol, crashing blood pressures, the whole nine, and clinically sick from a wound infection. We kept, how did we miss it? Well, we missed it because we were relying on their body to tell us they had an infection. And it's not reliable at all. And so in my mind, this is one of those game-changing things that as it becomes more readily adopted and as a standard of care, because it becomes best practice or better practice, I think litigious events may start surrounding people that aren't using this device, that then have people end up with sepsis or hospitalization or amputation, because we're relying on our eyes and nose and their body response to tell us when they're infected. But my 2 cents, soapbox moment.
No, I think that's perfect timing. I literally had a patient 2 weeks ago, same thing. I debrided the wound. He calls me the next day and says that I got the wound infected. I'm like, infections don't work that way, but he did. He was septic and everything. He had a white count, but it wasn't, I was like, I can't introduce a bacteria that fast, even if I wanted to. And, but yeah, it's interesting that you say that. So you're right. If I had that, almost like you said, that foresight, could have already kind of, might have been able to, it might have glowed and we could have had a discussion about what could happen before, but it's interesting.
I think too, the way we'll see more use of the imaging device is as those of us that are out talking about, good wound care and good outcomes and cleansing and all the things that you guys have been talking about, and have actual pictures to show what led us to decisions is going to really help. And let's face it, you have to have a champion for this in your organization that will take it, on up and, have people examine the purchasing of it. But when you see what you can do with it, that all you have to do is play with one time. and then I got hooked. I was at an SAWC, and Rosemary Hill, a clinician from Canada, gave an in-service. So when I went home, I'll never forget, I was standing in a feed store buying birdseed, and I was calling the people from MolecuLight, but it was in Canada. And they said, oh, we can't even talk to you about it because they didn't have clearance by the FDA here yet. So they had to toe the right line. But, eventually it did come down, and we are where we are today. But I think it's just as people get excited and learn to trust it, that we'll see a whole lot more use.
Yeah, and you're using this device for targeting debridement, for targeting cultures, for hygiene. But what I come across a lot of is that a lot of times I don't see, not in our clinic, but when I go help in the state, I see where people are not debriding. And I'm going to guarantee you show them this device and their debridement should improve. So.
Agree.
I think that's really true, Frank.
Yeah. Which.
Oh, sorry, go ahead.
Go ahead, Martha.
I was just going to ask if anybody's gotten to use the device with maggots in the wound.
Oh.
Have you?
No, I want to. I want to know what color maggots fluoresce.
I have one question in the queue. They just said, does the device link to the EMRs? Like, is the clinical imaging that's in there, can you connect it to your EMR?
What we actually do is we take a photo of the photo on the device.
Okay.
Some people hook it up to the USB port, so it's like a portable camera that you can, is that,
Oh,
so that you can take it straight into your EMR.
okay.
What we do is we just take a photo of a photo because it's easier for us. It does connect to Epic and some other databases. Those are not databases that we're using.
Oh, okay, okay. Yeah, yeah. Sometimes it's better to have it closed-ended too for security purposes, but I know Epic sometimes allow outside devices in, which is good. Okay.
How about you, Dr. Anderson?
I work in a military institution,
Oh yeah, he's not. They're not gonna let anything in.
and the particular record that we have, to get it changed or to add something to it, you practically have to go to Congress. And today, you know how that goes. So, you know.
So let's go to the next slide. All right. And Dr. Anderson or Martha, do you want to talk about this?
Go ahead, Dr. Anderson.
Yeah, it's. I think what it does is show the capabilities of the device. You obviously get an image of the device. You're able to use the device to get measurements. Then with the fluorescent component of the device, you can identify the bacteria. And then, as I've mentioned, we would react to that image, and that would help direct our debridement. When you look just at the image alone, you'd say, gee, that's a wound that, as Dot has clearly emphasized, needs a lot of cleaning, but also needs some good debridement.
And this is one of those wounds where sometimes nurses look at this or clinicians look at this and say, well, is it macerated or is that callus formation? But, you know, on the far right-hand image, you can clearly see the cyan porphyrin producing bacteria hidden under that callus formation. And so if you were on the fence about leaving that alone or changing, let's just change the dressing and see if we can dry that peri wound up a little bit. Hands down, you know, you've got to debride, unroof that sucker, and, you know, get the bacteria cleansed out, debrided out, scrubbed out, whatever you need to do.
I've had a question. Sometimes it's deeper red and then sometimes it's sort of pink. Are you saying that it's because it's down underneath, kind of hidden under cells, tissues?
When we see hidden abscesses, we see that it's almost like, I mean, I would almost call it a halo type thing, but it's pinkish red, but pink is subsurface.
Okay.
So, and it's how we've found numerous hidden abscesses, numerous.
And I think it really points out because, well, the palms and the sole and the soles of the feet anyway are thicker. And when they're macerated, they're like a sponge. It just soaks everything in, odor, bacteria, fluid, everything.
So you make a very good point, Dot. So in that wound, sometimes when there's that callus and that particular fluorescence, when you debride that callus, you'll actually see a darker fluorescence.
Yep.
Well, Dr. Anderson, let's go to the next slide because I think the next is some of your work. Maybe you can highlight a little bit more about what we're seeing.
So we just had a paper accepted for publication, and what it emphasizes is that not only can you get information about the wound, but there's a subset of patients that the fluorescence actually extends from the wound into the surrounding tissue. And what we would start with is exactly what Dot was talking about. We would clean that wound and do a surface debridement. But if that fluorescence continues into the surrounding tissue, we've labeled that wound-associated cellulitis. So we think that indicates that there's bacteria now that is spread from the wound into the surrounding tissue. It's in that case that we would add antibiotics. If it's only in the wound, we generally do not. But in this case, we would add antibiotics, and we've had some good experience following those patients in the series that we just had published. Being aggressive in treating that invasive component, it's cleared with follow-up, and none of our patients have ended up requiring admission for an invasive infection.
So you said peri-wound cellulitis. What was that term again, Dr. Andersen?
So we call it wound-associated cellulitis. I say that because I think it's very important. If you take a patient with just cellulitis and you scan a patient with cellulitis, many times you don't see anything with the MolecuLight. But if it's a wound-associated invasion of bacteria, this is what you see up here.
Right.
I had several questions from the audience. The first one was just, are there any CPT codes associated with this fluorescent imaging that you guys know of? I guess you can't probably
Martha?
be specific about them, but you could just say they're out there.
So there are, if you're licensed to bill for DME, you can bill E1399. That's the proper DME code for using the device. For those of you that are billing Medicare evaluation and management codes, E&M codes, for interpreting the device, you get 2 additional Medicare points for your medical decision making. So it elevates your level of E&M if it's charted correctly. And then the other 2 codes are 0598T, T like Tom, and that means that you're evaluating a particular location on the body. 0599T means you're evaluating an additional different location. So let's pretend we have wounds on 2 feet. Let's pretend I have 2 wounds on the left foot and 2 wounds on the right foot. I would bill, my practice would bill 0598T, 2 units, 2 different wounds on the left foot. And I would also bill 0599T times 2 units because there's 2 wounds on the right foot if I use the device to assess all 4 wounds. So I don't know if that makes sense, but they do have guidance or advice on the internet that you can look at for 0598T and 0599T. And then for DME people, there's also a HCPCS code that you can bill for the dark drape. I'll tell you that we have not been successful in getting payers to reimburse for the dark drape, but we continue to report those codes to Medicare and the payers. So with the hopes that they may pay eventually.
So Martha, again, I work in a military hospital, so we don't get paid. How many wounds? So you said with 2 feet, you're going to bill that much. How many wounds would it take to pay for a device?
I haven't calculated, and I will tell you, it depends on the MAC. Not all MACs have agreed for reimbursement. I've been very lucky. The MAC that I started out in was WPS, and they agreed. I petitioned them, sent them an email, and told them why I wanted this device covered, and they covered it. We are still petitioning some of the MACs, and so not all of them have coverage. And then again, my guess is it depends on how many devices you purchase and if you're getting a bulk discount. But I'll bet you MolecuLight could crunch those numbers for you and let you know. Right now, WPS, Novitas, First Coast, Palmetto, all currently have coverage.
Can we ask our consultant from
and the
MolecuLight?
Noridian also pays. I have a call with CGS in the next couple of weeks. We're working on pushing CGS to try to get coverage as well.
Yeah. And I'm sure we can go to their website and get a representative to give you those answers. I usually stay away from reimbursement and all that. I leave that to the director of the clinic. But let's go to the next slide, because this was interesting. Actually, this was the Delphi consensus guidelines impacting fluorescent imaging on wound outcomes. And actually, Martha, Dr. Andersen, you were both on there along with some other people that we know. But Martha, can you start telling us what this was about, why it was formed, and what the outcomes were?
You know, the Delphi consensus was formed to try to give us some standard of care of what we're all experiencing. Most of us are experiencing when we use this device, and also try to give us that decision tree so that we have a more standard or uniform way of using this device, and also that guidance to make sure that we're not missing things when we don't have to. Dr. Andersen can probably talk to the clinicians that they interviewed on the Delphi approach. Do you mind, Dr. Andersen?
I would kind of summarize it by saying, I think it's clear that it's very useful and exciting technology. So that's kind of a given right now, I think. But the question is, then do we use it on every patient? Do we use it on every clinic visit? So what we tried to do with this document is get some consensus about when it's appropriate to use it. And again, try to base that on opinions of expert users or people that had experience. So it's an opinion based on what people have found most useful and where they feel that should be utilized in their practice.
And I think the most interesting thing about the Delphi approach, we had the Dr. Andersens, the Dr. Johnsons, the Dot Weirs of the world on this panel. We're not talking about entry-level people that are still trying to figure out signs and symptoms or don't realize, oh, if it smells like baking bread, it's yeast. If it smells sweet, it's Pseudomonas. I mean, we're talking about extremely experienced people in the wound industry. And it was an international group, multiple countries that participated. And you have people saying 96% of the time it led to improved wound healing, 78% of the time it was reducing rates of amputation. And I love hearing the Dr. Johnsons, the Dr. Andersens, the Dot Weirs talk about this. They are so experienced with wound care, and to see them get fired up and excited about this, diagnostic equipment, and myself excited about this diagnostic equipment. We're years into our practice. We're not newbies, and it changes our practice. It changes how our patients get care. And that's a big deal to me. It changes whether or not my patients die from sepsis at the age of 85 versus dying from old age. So,
Well, I think that having this technology, number one, will guide people into debriding properly, but also validate if you're in the right heading. When I bring technology to our clinic, having 10 doctors, I like to play around a little bit. And one time I had something that wasn't even a technology in wound care. And somebody said, "What is that?" And I said, "I'm going to see if you're going to debride properly today. So I have something that will objectively." And would you believe that when the doctor finished and I walked in there, it looked like somebody stuck a pig. I mean, there was blood everywhere. And at the end of the day, he said, "Well, how did I do?" And so I know it can change practice because it gives somebody visual.
you can stop before they start spurting. It's okay.
Yeah. All right.
So Frank, let me make one other point. So we work a lot with our plastic surgeons, and this has become an important modality for our plastic surgeons. So for example, if you're preparing a wound for a split thickness skin graft, the last thing you want to do is put a split thickness skin graft on a wound that's colonized. Or if you're planning some kind of a rotational flap, the last thing you want to do is do that on a colonized wound. We've already talked about the biologics, but we've extended this to looking before we do a complex procedure to make sure that we're not burying bacteria, so to speak. So that's another usage.
Yeah. All right. Let's go to the next slide. And Martha or Dr. Andersen, do you want to? This is still from the Delphi data.
On our end, we actually, and I've shared this in several different webinars and lectures, but we actually had one of our PCR companies call us and say, "Did you fire us? Are you using somebody else?" Because we had only submitted about 8 samples that month. And keep in mind, we're in multiple states. We treat thousands of wounds a week. But when we're able to remove bacteria real time at the bedside, real-time feedback, and we're not guessing whether or not there's bacteria in the wound. We didn't need to culture. And then again, watching the wound, shrink from week to week, it just reinforced that we were making the right decision, the right treatment options and choice. And I will say, back to the case with osteomyelitis, and we've only had maybe 2 or 3 cases that I'm aware of where we fluoresced infected bone. But we were able to remove that infected bone, that infected tissue by using that bacterial fluorescence imaging, and get rid of that infected bone at the bedside. Now, I'm not saying that whole sacrum was infected and we avoided an OR visit. I'm talking about very small areas of bone that were infected. But at the same time, we were still able to clear it up and get that wound to granulate in. So
it's definitely reduced the number of cultures that we do in our clinic.
Dot, I promise I wasn't going to bring the past, but I'm going to have to. You were the one that introduced me to a low frequency ultrasound, and you mentioned it in the beginning of this episode, but have you used the device before and after low frequency ultrasound?
I'm sure we have. We're using it just kind of every time we go into a room where we're going to do, especially an extensive debridement, and use the ultrasound. Yeah, the answer is yes, whether I could pull up pictures, and you can see a difference. There was a question in here, since we're talking about ultrasound, that Terry Swanson, who I'm so thrilled that she's on the call, she was asking about the aerosolization. And Terry, that's a very interesting question. What I was talking about, I can see it because she uses ultrasound also. I can see it in the runoff of the fluid as it runs off the wound. I'd have to look at the videos again to see if you can actually see it in the air. It hasn't jumped out to me if it did, but wouldn't that be something? I'll tell you what, Terry, I'll look at a video. We can maybe try to find one tonight and show it to you. But I mostly notice it in the runoff of the fluid.
And maggots.
What's that?
And maggots.
When they ingest the debris as it goes through their alimentary tract, there's antibodies or something that treats the bacteria. So what their excrement might look like would be interesting.
Yeah, but in the clinic, when we hear we got a runner, it may be a way for us to find the runners.
Right. I get a video of maggots using this device gets $50 from me. Go.
All right, let's go to the next slide. And Dr. Andersen, I believe this is yours. I want you to talk us through this, how the machine's been used, how the device is used in the clinic.
So this is an example of what I referred to as a MolecuLight assisted debridement. So we identify that there's bacteria in that wound or around that wound. And then oftentimes we'll use the video while we're actually debriding, or we'll debride, but then still have the machine so we can just re-engage the machine with the wound. This particular patient, again, a diabetic foot ulcer, there was some colonization there. When we finished, we were comfortable enough that in this particular patient, we put him back in a total contact cast, again, feeling that we had removed most of the bacteria. Now, we would still put an antimicrobial dressing if we didn't completely clear that wound, or many times, again, seeing the amount of bacteria, we would still put a antimicrobial dressing along with the total contact cast.
I do have a question. I saw you turning the lights off, but unlike Dot's clinic, we have windows and not many shades. When I can't turn the lights off like that, what do you recommend?
Shades on your window, I guess.
But we have the drapes that you can get with the device that I've never even had to use one because we've never had any windows in our clinic. So
Yeah, we use the drapes when we go up to the ward, but it inhibits, I think, certainly the flow.
I gotcha.
Have to take a few seconds to get the drape positioned over the wound or the extremity. Make sure the device is inside the drape all the way so it's nice and dark. And also, I will say that MolecuLight does a great job at training you and pointing out your mistakes in the beginning, which, mistakes are the fastest way I learn. You also have to be careful about what's under the leg, because if it's a white sheet or a white rubberized pad or something like that, sometimes it can blow back and cause different fluorescing that may or may not be accurate. So I think he has a blue drape underneath this leg, which is appropriate. But again, you get full training and reinforced training and ongoing education as much as you need on how to interpret the different fluorescing images and different color span that can show up on the device. So the training's important.
Right. So let's turn our face to research a little bit. So next slide, and Martha, this is something that was published. Can you tell us a little more about this study?
Yeah, this was the fluorescence imaging that was enhancing detection of bacterial burden by 4 times, and then the changes in treatment. So we start with all wounds, and we can see that there was 350 patients enrolled in this study, but 69% of the time, this is the study that Dr. Serena was talking about also, that flag trial, but 69% of the time it changed treatment in the wounds. The bigger thing was that 85% of the time, clinical signs and symptoms, that assessment of clinical signs and symptoms was missing the detection of bacteria. And so when I saw this study, I thought, aha, that's exactly what we're seeing in the clinical field. And that 85 to 90% of the time, the treatment option we would have chose was wrong or incorrect. And so that 85 to 90% of the time, what we thought we were going to do when we walked in was not what we were doing when we walked out. And so it just speaks to the appropriateness of MolecuLight. Dr. Johnson, do you have kind of that little bit of checklist of how you decide what wounds to use MolecuLight on, when to use it, when not to use it?
I mean, not necessarily. I mean, honestly, I would use it on everyone if I could. Just be honest, but not necessarily a checklist. Not really.
What are the wounds that you for sure, hands down, would be using this device on? Or what are you?
So of course, not like maceration, wounds that are macerated, serious drainage, wounds with previous history of infection that is already, whether they've been hospitalized for it or it was a wound that they've been discharged for that I'm treating now. Not necessarily like surgical wound dehiscence or things like that. I don't mess with those too often for those type of things. But other than that, that's what I would use it for. Of course, I mean, I was looking at the charts. I could see people using it for venous leg ulcers. So that'd be smart too, because that's another reason. Maybe the reason why we struggle healing venous leg ulcerations. So that'd be interesting. I would have to see if there's just a study that looks at VLUs and using MolecuLight, because that'd be interesting.
Mm-hmm. We also use it when the peri wound looks different colors from the surrounding tissue. It's what we call a heralding sign, that sign that something else may be going on, possible cellulitis or maybe hidden abscess. And then again, in the elderly, anybody that's on autoimmune or chemotherapy, prednisone, drugs that are somehow suppressing the immune system or inflammatory response. Is that something that you do typically?
Yeah, that's exactly that's exactly how it would go. So like I said, yeah, I would guess susceptibilities, wounds that that'll be susceptible to infection, or like I said, have history of previous infection.
And that 10 to the 4th power, that's the important part. 10 to the 4th power is clinically infected, not 10 to the 2nd or 10 to the 1st or 10 to the 3rd. 10 to the 4th is clinically infected. Right. And so their FDA indication shows that they show 10 to the 4th power and beyond, not under. Although at the same time, I had a saying when I worked at the hospital, treat the patient, not the monitor. And so if your gut is telling you that something's not quite right with that wound and the MolecuLight device is not fluorescing, much like Dr. Andersen said earlier, we would still do a tissue culture and just verify that there's nothing hiding out there that, that may not be fluorescing with the device. So.
Yeah. And Dot, I have a good question for you. Keep in mind that we have students here also, so this may be a little more basic, but I'm looking at that picture. Would you tell students, or if somebody new getting into wound care, why maybe the pigment on the patient may hide some of these clinical signs?
Oh, well, I mean, just dark skin in general, but as you look at that wound, and that peri wound, I mean, you can see it's hyperkeratotic, it's thickened, there's a little bit of maceration there. And I mean, that's a really good time to educate on improving the wound edges. And that's all part of wound hygiene, good wound cleansing, good debridement, making sure that the edges are open. And so, it's a good lesson there. But I think the hyperpigmentation just shows that it's thicker skin around that area, and that needs to be taken down. That's the beauty of it, just not only with this, but when we, because we don't bill for it. And so we will take it in, not on every single patient, but if we, everybody gets a patient in and they come in and their leg is a train wreck. The drainage increased, so their leg got all macerated or denuded, or there looks like there's a lot of inflammation. I mean, if we get a chance to pull out my pictures, we had one come in and the whole leg was green. I mean, it was a disaster, but it really gets your attention to the scope of the problem that you're looking at. So we use it just to really make ourselves feel good about what we're doing and feel confident of where we need to go after. I don't know if that answered your question or not, but
yeah, it did. But also, one of the clinical signs is also redness. How would it, on that picture, how could I tell if it was red, the peri wound skin?
I mean, I don't see any redness there at all. That's one thing about dark skinned individuals, is you're not going to see subtle redness, subtle changes of redness. Now, there's redness that indicates like erythema type redness, and then there's the redness of the bacteria sitting there. So certainly if you're worried about bacteria sitting there, you could use the imaging device. But the thing about dark skin is just like with pressure injuries and assessing people with dark skin, you got to turn the lights on. You got to really take a good look at it and feel the skin, see if it's warmer or cooler than the adjacent tissue. It really takes enhanced assessment skills when you're dealing with dark skin. I don't know if anybody else has anything to add.
Yes. Oh, anybody else?
No, I agree. It's definitely a challenge. And like you said, you have to have good lighting in your examination rooms, or even if you're in the hospital, bring an extra light or use your cell phone light to assess those. Otherwise,
I take my cell phone now all the time when I say, I'm not taking a picture of you. I'm just using my flashlight.
Exactly.
And, just even with our clinic cameras, many times I can see, I will notice things on an image just in a regular camera that I maybe didn't see with my own eyes. So
That's true.
there's a lot that these things will show you. Of course, the bacteria is a big deal.
Yeah.
Tactile sensation too. Is that area cooler or warmer than the surrounding area? Does it feel tougher? Does it feel like it's indurated? And oftentimes tactile sensation goes to the wayside because we're so used to using our eyeballs, I think. But
yeah, and I ask that question because a lot of times I see it where we miss it on darker pigmented patients.
Fluctuation.
Frank, I'll get back on my soapbox a little bit, Frank, that when you look at that wound, it looks like there may be some poutarage around that wound. So there may be a component of lymphedema that may be secondary to chronic venous insufficiency. The most common mistake, I truly believe this, the most common mistake made in wound care is we treat the wound and we forget to treat the disease. This is a wound that probably would benefit very significantly, not only with good debridement and good wound care, but good compression. I am assuming that's a leg now. I don't know that for sure, but you just have to treat the disease. You just can't do wound care and not understand and treat the etiology. Many good podiatrists have said it's more important what you take off from a diabetic foot ulcer than what you put on, getting the offloading. And, you know, I believe the same thing with venous leg ulcers. It's more important. The compression is probably much more important than the dressing that you put on a venous leg ulcer.
And I think edema is a very underrated assessment that we need to make and assume is there. Melody Blakely is getting ready to publish a paper in today's wound clinic, I think it is, on edema. And, you know, we know lymphedema, we know venous edema. We compress, as long as they have adequate flow, we compress a lot of people with diabetic foot ulcers because they have just this inherent edema. That's why I like the little disposable negative pressure devices to use just for a couple of times to reduce the peri-wound edema. You see, you know, you reduce that distance diffusion so the oxygen travels better through the tissues. And it's amazing what you can see just by compressing somebody.
And I don't think we refer out to vascular soon enough to assess for perforators. And so deal with that recidivism and, you know, the fact that, gosh, it just keeps coming back. Well, that might be a sign that they have a perforator. Have you had them checked by vascular? No, why not? Dr. Andersen, that interdisciplinary approach, we've got to utilize all of these people in our arsenal if we want to get them healed and keep them healed. So no shame in referring.
Yeah, and Dot, I can't wait to see that article because actually I'm at a lymphedema conference speaking here, and there's more interest in the wound care world. But when it comes down to all these wounds, there's a lymphatic component to it. I walked into my clinic one day, okay, and everywhere I turned, there was a lymphatic component. And it wasn't until I started looking for it, like that, you know, you drive a red car, now everybody drives a red car kind of thing. And it's unbelievable because now we're getting better success by dealing, like Dr. Andersen said, treating the patient. So let's go to the next slide. And Dr. Andersen, you mentioned earlier about the cellulitis. So here's some of your pictures. You can walk us through it.
So I mentioned this a little bit before, that if we see a wound where the fluorescent extends out beyond the wound margin, the first thing we do is exactly what Dot has been talking about, is a good thorough cleaning of that skin. And a light debridement, if there's any macerated skin, and then we reassess. If we're able to remove that fluorescence by those two measures, then we would not call that a wound-associated cellulitis. It's in those patients that after you've done all of the cleaning, the removing the necrotic tissue, that you still have the extension out into the tissue. That's when we would make a diagnosis of a wound-related cellulitis.
Those photos are neat. So there's no break in the skin. That is all cellulitis that you fluoresced. Is that right?
No, there's a wound there. So unfortunately, everybody's picture is kind of over part of the wound. So I don't know how to remove that. How do I remove that?
Just slide it over.
Come up here.
Go to the top. There's a
There we
black.
go. There we go. Yes. So this is sorry, I couldn't see the rest of the picture. So here in the center is the wound, but then you look around the margin of the wound, and that's where you see the fluorescence outside the margin of the wound. And that's where we would put the patient on antibiotics. And we've had good resolution using antibiotics, as I mentioned, with in our series that we just published, that none of those patients went on to develop an invasive infection that required hospitalization or IV antibiotics. I think catching it early, you have the opportunity to be a little bit more aggressive early with appropriate antibiotics. And at least in our experience, that will clear and the wound will heal, as you see in the bottom picture.
I've never even considered using this for cellulitis. I've never done it.
Well, again, I want to be very, very clear that I do not, excuse me, I do not feel it's a good device to make the diagnosis of cellulitis. So if you have somebody with a swollen red lower extremity and you put the MolecuLight on that, you're probably not going to see anything. If you have a wound and you see that fluorescence extending out beyond the wound, I think that's a different type of invasion of bacteria. So we call that a wound associated cellulitis. So it's maybe cellulitis is not even the appropriate term. It's bacteria that has now invaded the surrounding tissue outside the confines of the wound. And that's where we would treat it with the antibiotics.
All right. Let's see. Thank you, Dr. Andersen. And let's see if we can get Dot to show her pictures. See if we can make her a presenter.
Let's see. Okay, this is also going to show you how disorganized my computer is. This is just, I want to find some, okay, so here's one. Well, you can see a little bit there. I was looking, somebody had asked, let me move the pictures. Somebody had asked about a negative. I know I have some in here. But I want to, the main thing, yeah. I mean, you can see a little bit, but you do get negatives. You do get some that are completely dark. So what I want to find, if I can, okay, so I mentioned that if somebody comes in and their leg is just a train wreck, here is a train wreck. He came in yesterday. I don't think this is going to show much, but some very, very denuded skin that he had. Look at that. I mean, it's just, his whole leg lit up like that. So, I mean, we knew we were in trouble. We knew we had a lot of work to do when we knew we were in trouble. So what I just want to find is one that we are using an ultrasound on. I can usually see, because it usually, okay, here, how's that for a red one?
Yeah.
I mean, you know, then this leaves no question, you know, when you flip it on, and it doesn't necessarily have to look really bad.
We're
But-
not seeing the big photos, Dot. We're just seeing the small thumbnails.
Oh, oh, really? Oh, darn. Okay. I don't know how to fix
I know.
I don't know how to fix that. It's showing up on my other, okay, you don't see that?
Just the thumb.
No.
Oh, okay. It was a really good idea.
No, I mean, we're still seeing it. Maybe you got to minimize that and find the picture on your other screen.
Well, at least make them bigger.
Oh, there you go.
There you go.
This is a skull. But
Oh, really?
Yeah, I was like, well, if you can't see the video, then I was going to try to show a video of the ultrasound. But going back to the guy who was a disaster that came in yesterday morning, here he is. I mean, you can see his whole leg is just lighting up, not only with the green that just shows the scales. And this was very, very inflamed, denuded tissue. You can see the Pseudomonas. This is a big area of Pseudomonas. Here we have the bacteria. This is a dressing in a trash can. So Chuck, you were talking about being able to see it on a dressing. So can you see my pointer at least?
Yes.
Yeah, so
Yes.
that's a dressing in a trash can. I thought I had
Beautiful.
one other up here that was pure. Okay, so over here, that's the wound, and then that's the dressing right above it.
Oh,
But yeah, it tells you a lot. It tells you a lot. And I don't know how to because I'm not smart enough to know how to show you these videos. But yeah, it's fascinating to see. This is showing a culture that's showing that we got a good culture. I don't know that you can see it at the very tip of that culture.
we can.
Some bacteria on it. So, anyway, I regret that I can't show you the video. That's what I was thinking. That's what I was hoping to be able to show.
Hey, and Dot, have you used it on incision, surgical site infections?
I have not.
Okay, because now I'm starting to think, you know, when we get one that dehisces, I wonder if it's because of bacteria.
Has anybody else? Martha, Chuck, Alton, have y'all used it on a surgical site?
Yes, we have. It's the first one was actually my partner, a limb preservation podiatrist. had a post-op patient, and the incision was a little indurated, and he asked me to go ahead and scan that. And what you could see right at the end of that incision was like a little micro abscess, and it clearly, the incision itself flourished a little bit, but there was a pocket. So we took out one suture and drained a little suture abscess. And then he cleared up very promptly. So we've used it quite a bit on incisions. If there's any question of is there a surgical site infection on an incision, then we will scan those. And sometimes, like I mentioned, we found, a little area where we'll take out one suture, there'll be a little pocket, and then the rest of the incision will go ahead and heal.
It would be so cool to get a picture of, because we've all gotten into little areas where it's purulent looking material, but it's probably just sterile pus. It was just reacting. To get a picture of clean pus that didn't have any bacteria in it.
Yeah.
That'd be cool.
I want to see if urine in a catheter bag fluoresces when they have a urine infection versus no.
Yeah.
Definitely indication.
So it sounds like you guys have some work to do and get back with us. Maggots, what else?
Feral pus.
Pus. All right. Well, let's go to the next slide. I think we're coming very close on the hour and a half, so time flew by. I do want to tell you, thank you, Martha, Dot, Dr. Andersen, Dr. Johnson, for being part of this. Definitely learned a lot. Go ahead, Dot.
May I make take a short moment to make an announcement? So I'm part of the International Wound Infection Institute, the IWII, which anybody can join. And on October 21st of this year, we have our very first annual Stop Wound Infection Day. And so I invite you to go to woundinfectionawareness.com. That's woundinfectionawareness.com. You can look for a Facebook page and join us on the Facebook page, but it's going to be the first annual Stop Wound Infection Day. International. Thank you.
Well, thank you.
Dot, is that going to be a virtual meeting or a?
It's really just a day, and we have a host of international groups that have signed on to support it. And so that's the website, and there will be different educational offerings. This is our first one, but it will grow from there. So woundinfectionawareness.com. Go there. There will be different videos and things about people talking about that. Thank you.
All right. You're welcome. And so with that being said, when you raise your left hand, Dot, I thought you were going to make a different announcement. So
that was my right hand.
Oh, all right. There you go, left. With that being said, our next virtual wound round will be on managing challenging wounds. It'll be on December 2nd, and we do have another expert panel. So stay tuned for more details. Next. For tonight, I do want to profusely thank MolecuLight for being our sponsor. Definitely the technology is out there for us to use, for us to enhance the care that we provide to patients. So thank you, MolecuLight, for sponsoring tonight. And with that being said, I do want to say thank you for attending, and we'll see you on December 2nd. Bye-bye. Now, Dr. Andersen, Dr. Johnson, Martha, thank you so much. I know that when people volunteer for this, it's kind of unscripted, so we don't know which way it's going to go. So it went great. Thank you.
Thank you.
I'm happy to be